Dan, do you have a question?
Yes, sir. I'd like to know a little more about heart attacks.
It's the #1 killer of the adult population in the United States. There are some 4,100 heart attacks each day and 600,000 deaths each year in the United States. So it's a real problem. Jane?
What causes a heart attack, and why do people actually die?
Well, consider the heart as a pump, and a great pump, with tremendous reserve capacity. It's a muscular pump, and as such needs a blood supply with nutrient vessels. There are 3 major vessels to the heart, and when blockage of one of these vessels takes place, there's interference of the blood supply, and the muscle supplied by the blocked vessel usually dies off. The damage to the pump, we either die, or if we live with less of a pump and become less of a person.
Dr. Barr, what causes this blockage?
A disease called atherosclerosis, or layman's term is a hardening of the vessels. Our lifestyle allows the risk factors, such as hypertension, cigarette smoking, and cholesterol, etc., to incubate over a long period of time, years, leading to about a 90-95% blockage in the vessel, which finally ruptures, allowing clot or spasm to close the vessel. Within 6 hours, there's total damage to the muscular pump.
I was just wondering, Dr. Barr, what kind of heart attacks are they? Are they different?
We try to divide it into 3 kinds in order to get across a very important message. The first kind is the massive heart attack, the one that stops you dead in your track, or cardiac arrest. We call this the acute myocardial infarction, the medical term for this. Perhaps the most important heart attack to have is when it's in the beginning stages. Here you may consider this angina or unstable angina is the medical term. But this is the beginning of a heart attack, and it's important to differentiate because therapy or action will differ somewhat depending on each kind.
How do we help the person that's having a heart attack?
We call this response the first responder. And in the case where you have cardiac arrest, you need to know cardiopulmonary resuscitation and know how to do it. When you're in a process of the heart attack itself and the damage is taking place, it's important to have executive-minded people who will get you to the cardiac care system. Here, the patient doesn't put up much of a fuss because he's in severe pain. So it's important for this person to know exactly what to do in order to get them into the system. Perhaps the most important is in the stages of a beginning heart attack. You still need someone to get you into the system, but this person has to do a little more, and we'll get into that. This is what we call the emergency cardiac caregiver. This person has to be a little bit more alert, active, knowledge, and be prepared to take time out of his or her life, especially when there's no peer pressure upon that individual.
Can the heart attack victim be helped, Dr. Barr, once this occurs?
Yes, the person, I'm sure it can be helped. We've seen that risk factor reduction when the disease is in the incubation stage can reduce heart disease. What really is needed is the identification of the risk factor when the heart attack starts. Chest pain is that risk factor, but we have to understand it. And I'd like to show you on the board some aspects of it. Here, life begins and goes on until something terminates it. And this is the cursor that terminates it. And it may be young in age, or it may occur a year older. The real question is, when does this event marker take place? It takes place when there's rupture of that atherosclerotic plaque, that hardening of the vessel, and there's total occlusion of that vessel. In other words, a break in the action, blockage. Now, if we were to take this and dissect it under the microscope and perhaps look at the sequence of events that normally takes place when this occurs, and perhaps work backwards in time, we see that the final event is a sudden death. Before that in time is when the damage is taking place, myocardial infarction. But before that in time the patient is suffering angina or unstable angina, severe discomfort, but not as severe as when he's having myocardial infarction. Before that, the heralding onset is with chest pain. And this is when there's severe amount of discomfort that leads to the angina, MI, and sudden death. But before that, and most importantly, there's a milder discomfort that's not considered chest pain by the patient. It's mild, and it may occur hours to days before the chest pain becomes severe, because once this starts, there's a cascade of events, and this goes pretty fast. In fact, sudden deaths can take place even before myocardial infarction. Sudden death doesn't have to take place after the damage. It can take place when there's just lack of blood supply to the heart itself. Most importantly is this stage here, when there's chest discomfort before there's significant chest pain. We call this area the prodromal stage. It's very similar to the beginning of a cold. When you feel a cold coming on and you take some medication, aspirin, etc., you can fend it off, nip it in its bud, and prevent it from occurring. The same thing with heart attack problem. If you are aware that there's minimal symptoms, and they are usually central chest discomfort that's coming and going, and we call it stuttering. It keeps coming until it becomes progressive and then that doesn't go away. But if you get involved at this stage, what's important here is that there's no damage that has taken place. There's blockage or obstruction without destruction. And since this occurs days or hours to days before this occurs, it's very important for emergency cardiac caregivers to get involved here to save not only the life, not only the muscle, but also the vessel itself, and the patient walk out of the hospital with a great quality of life ahead of him.
Dr. Barr, heart attack is scary, and it's serious. I don't understand why it's such a hard nut to crack.
That's a good question. That's why we're here today, to see if we can unravel the problem. In order to do so, let's see if we can act out and see for ourselves what the take-home message is. Jack, the first kind of heart attack, this area we call cardiac arrest. Pretend that you've had a cardiac arrest. You were at work, and I don't know what led up to it, but here you are lying on the floor, and you have no pulse and no blood pressure, and you're not breathing. The first responder to this first kind of heart attack knows exactly what to do, because there's severity 4+.
Use a blue
there's
call
no denial,
Call
and it's
911.
easily recognized by the first responder as well as by the community itself. There's community peer pressure because everybody knows what to do. This goes on every day in the United States. And when the paramedics come upon the scene, they also know exactly what to do.
Glad you're here.
They've been trained in this. It's easy to recognize. There's no fuss because the patient is out. And the community knows what to do. The paramedics know what to do. And the patient is, if he makes it, is taken into the hospital as a cardiac arrest. That's the first kind of heart attack, first responder, and the community as well as the paramedics.
I couldn't breathe in the nose foot. I'm trying to hold my breath.
And that's when the heart attack is an evolution, when there's complete blockage and there's damages which is taking place. Jack, would you bring your chair up here and let's pretend you're in the office and you've had chest pain now for an hour and a half, and you want to tell us about it?
Oh, I had this crushing feeling right in the middle of my chest. I've had some pain on the inside of my arm here, running down on my left arm. It's just seems to be getting worse and worse all the time. Really becoming excruciating.
Jackson allowed
It's a little hard to
discomfort,
breathe.
and the first responder who comes upon the scene notices that the patient is in distress. It's obvious. It's easily recognized. and the person wants to be a first
I'm gonna
responder
go call the
and get them
ambulance
into
right
the
now. I'm gonna go call
hospital
911.
situation. And the community, the people in attendance or present around the patient having this
good.
severe pain
Good.
also recognizes the fact that this patient is
Paramedics
in
will be
distress.
here.
So it's easily recognized. And the
Right
patient
here.
does not put up any fight, no resistance, no fuss, because he's in extreme distress.
Excruciating pain right in the center of my chest. Breathing.
Everyone knows what to do. It's obvious, it's easily recognized, the patient puts up no fuss.
Okay, sir, we're going to take you to the hospital, get you checked out, okay? Okay.
Okay, thank you. 5 minutes, heart attack. We're going to divide in 2 stages. We're going to divide into the first stage, that which usually takes place in the community, and the second part, we're going to show you what needs to take place in order to cut down the mortality of the heart attack problem. In the first stage, the patient is having the beginning signs of a heart attack, but he's having minimal the symptoms, the kind that he can deny. Jack, you want to take it from there?
Jane, do you have indigestion from that lunch we had?
Oh, no, lunch was good, Jack.
I seem to have this discomfort in my chest.
Well, we got to get this meeting done. Why don't you take a tongue and we'll finish this meeting.
Well, I know, but I had this before the other day. It showed up, and it sort of scares me a little bit. It's coming back now, and I didn't know whether maybe I was hoping it was indigestion. You know.
It's probably indigestion. You could go to the doctor tomorrow.
Okay, well, we'll just.
Got to
Wait
finish
here.
this. We got to finish this work.
Well, I know how important it is.
Yeah.
Notice the sequence of events. The patient has minimal symptoms, maximum deniability, and then the first responder hears the message, but also has his business or her business as usual and contributes to the denial. This is probably why heart attack is the #1 health problem in the United States, why there are so many deaths in the United States, because the patient waits until the Mack truck is sitting on the chest when there's total occlusion, and that's when they enter the system. What needs to be done is intervention at this stage. We're going to replay this and show you what needs to be done. Jack?
You know, I don't know whether I can make it through this meeting or not. I keep getting this discomfort and this little bit of pain in my chest, and it keeps coming back more and more often now.
Jack, that could really be significant. I think you really should have this checked out.
Well, yeah, but I've got to go pick up the boss at 3 o'clock at the airport.
I'll tell you what we can do. We can call Sam down the hall and have her pick up your boss. We can go and get this checked out. It'll take a very short time, and we can finish that.
Well,
What's the matter here?
I'm
I
just
want you
having
to pick
this.
up Mr. Smith, because we're going to have Jack checked out. He's got a little indigestion, and it could be really significant. It could be the first stage of a heart attack.
Mr. Smith's coming where, Jack?
Like 380 Piedmont.
Okay, listen, I know where you live, I know where to take him, so I don't want you to worry about this. I want you to do what Jane is saying. I'll take care of this critical
Someone's
incident.
called the
I'll take care of
paramedics.
this. The paramedics are on their way. I called them, and well, here they are.
Somebody called and said you've been having some chest pain.
Yeah, I'm having a little discomfort. It's not too bad. It's sort of come and gone. And,
Where about is it in your chest?
it's just sort of all over. You know, it's not in any one spot. Just a real terrible feeling, you know. But
Would you like to go to the hospital when you're checked out?
Well, I don't like
Oh,
it.
Jack, I
You
think
die.
that's a very good idea. We got Mr. Smith coming in. We can finish this tomorrow. It's no
Yeah,
problem.
well, what are the people going to think when they're taking me out of here?
We'll do it very long fun.
Oh, they won't turn on the siren. It'll be very quiet. Okay, let's go, Jack.
If you promise not to turn on the siren,
No fuss at
and the
all.
light.
Good.
Okay, you've seen why the heart attack problem takes place and why people dilly-dally, delay, and wait for that Mack truck or that sudden cardiac arrest taking place. That set of circumstances, mild chest discomfort, excessive denial, driven by business as usual, not easily recognized, and when the first responder is there, also contributing to the problem itself. What needs to be done is for that.
Oh, is there a secret to working out the problem? How can we turn this around?
The first responder has to be able to recognize and be knowledgeable and know that the time to help the patient is when the heart attack is in the beginning stages. That there is no peer pressure to put on that first responder in order to do something. And the first responder has to expect denial and be prepared to argue for the patient to seek out early cardiac care attention. We call this approach the emergency cardiac caregiver. Be active, be heart-minded, be an emergency cardiac caregiver.
Dr. Barr, why is denial such an important part of trying to unravel this heart attack problem?
Well, Jack, it's because it's part of our lifestyle. We constantly forget about ourselves and live our lives as if we are indestructible, immortal. Very similar to what Larry King said and Mike Dickens not too long ago. And only are brought to reality when we are burnt. The secret is to try to minimize the burn and thereafter change the person. Heart attack is a great transformer and a great reality check. The secret is to nip it in its bud when the heart attack is in the beginning stages. Angina before myocardial damage or sudden cardiac arrest.
Dr. Barr, we can live without a lot of our reason to get rid of an eye or lose a kidney. Just how important is it to life activities to have a whole heart?
It's very important. That reserve capacity we talked about allows us to increase the amount pumped fivefold and do the things we want, strenuous tennis, marathon running, etc. With less heart action, we do less, and our quality of life suffers.
Dr. Barr, we've had a lot of good information today, but what final word could you say about this?
I would challenge the viewers to ask themselves if they were to have a heart attack, if they had that blockage in their heart vessel, where would they come in? Would they come in when they were having a cardiac arrest, lying on the ground waiting for someone to pump on their chest? Would they come in when that Mack truck was sitting there for an hour, when they're in the midst of damage? Or would they come in when the heart attack is in the beginning stages, hours to days before the total occlusion and the Mack truck is sitting on the chest? I think if you're smart, you'll be an emergency cardiac caregiver. So our message to you is be alert, be active, be heart smart, be an emergency cardiac caregiver. Thank you very much. Thank you very much. I don't have to describe to you the sudden death of the patient on the ground. But the patient having the Mack truck sitting on the chest, okay, the total occlusion. First of all, he looks sick. He really looks sick. And he'll be the first to tell you, I need a hospital, get me an ambulance. He's no denying. And he's describing something in his chest. It's an essential portion of the chest. It's deep and diffuse. Deep and diffuse. It's not on the chest wall. And he cannot localize with one finger or a hand. We'll say, tell us about it. And they'll say, it's not there, it's across. It's diffuse. It's not, well, if they tell you it's underneath the left breast or right breast or something like that, it's usually not, if they can localize it. If it's diffuse, deep, central, the term we use is retrosternal, but I think central is better. Middle of the chest, central, diffuse, deep. And it doesn't go away. It's there to stay. Because they're going to need nitroglycerin, morphine, and a hospital setting. They look sick, they're usually pale, and they're cold and clammy. Pale, cold, and clammy. And they're about ready to pass out. They're weak, they're dizzy, and they got to sit down or lie down. And I'll tell you that discomfort is starting to radiate across the upper shoulders and down into the left arm. And it goes down the inner aspect of the left arm, and it starts from the top and goes down. It doesn't start from the fingers and goes up. And it's not on the thumb side, it's on the inner aspect. It radiates down the inner aspect. Patients may feel, they may give you that possible divine sign. They'll tell you their arms are heavy. They cannot lift them, almost to the point of being paralyzed. They're weaker than a cat, whatever a cat is. Weak as a cat. Why is a cat weak?
What is it that's creating that pain
Total occlusion.
in the heart?
Total occlusion.
So I mean, has the blood?
It has nothing to do with the blood supply to the arm. Has nothing to do. It's a referred pain. The pain fibers are in the heart and get referred to the arm. Has nothing to do with the arm. Arms are heavy. They look weak. They got that. They may have some other symptoms with it. Shorter breath. Maybe even go on pulmonary edema. Congestion. They're very weak. They may pass out. Syncope. Nausea and vomiting. Especially with the inferior ones. And what it's not localized pain underneath the breast, not radiating, and that's classical. What percent of the time do you get classical? I don't know, but it's classical because it's a high percent. If it's atypical, anybody can miss it, but don't miss the classical. It may radiate to a tooth or to the jaw. No one should miss the classical. Highness of suspicion should pick up the atypical. And how about, that's in total occlusion. How about the 6 hours, the 12 hours, 24 hours, 48 hours before he has total occlusion? What kind of history does he give you? He or she, sorry. What kind of history? History is something central, not heaviness, not necessarily. It might be tight, but it's not the Mack truck tightness. Misery. In fact, they'll be first to tell you it's not a pain. It's not a pain. In fact, that's one of the reasons they don't come in. What they mean is not severe. Huh?
I had a spell.
A what?
Spell. You know how the older people will say, I had a spell?
Oh, yeah, spell.
Spell came over.
Well, sometimes with some people you have to practice what I call veterinary medicine. You can't get much out of them, and you've got to mimic certain things. Is it here? Yeah, and then you can say yes or no. But sometimes you've got to get it out of them, and then you got to be more aggressive with your history. History is not all passive. History is aggressive at times. It's essential. It's a misery. It's a discomfort. It's a heartburn. It's an ache. Don't feel well. Want to lay down. A little nausea. Just a little. Not much vomiting. It comes and goes. It comes and goes. It comes and goes. Once more, comes and goes. We're talking about prodromatin. Before the Mack truck, it comes and goes. It comes with activity and is relieved by rest. And people insidiously go towards the couch because they know that's a way of getting rid of it and hoping that with a good belch it will go away and they'll be okay in a couple hours. That's what they talk themselves into. And they won't tell the spouse a lot of times. But the spouse, by living with them, knows something's wrong and shouldn't be passive, but should be active and say, you don't look well. I'll be all right, things like that. But actually going after it. And if you're concerned about the number one illness, it kills and maims, why not a checkout system? In and out, and make a proper decision. If they got telltale signs of meaningful chest pain or meaningful chest discomfort, when coronary caregivers play an active role. It's a discomfort that comes and goes, usually lasts 5 minutes, goes away, 2 hours later comes back. They came through the night, lasted a half an hour, got up and took some milk, went away, woke up, and still had it off and on. And then at 10 o'clock it became prolonged, and here it is 12 o'clock, they're in the emergency room, clamming. What happened? They had the blockage, and they were forming a thrombus, a ball valve thrombus, coming and going, and then it blocked off completely. and then it made the entire area ischemic without blood supply, and then the MAC chuck was sitting on the chest. And then you're dealing with thrombolytic therapy, you know, half to 80% of muscle being damaged. Where if they had come in just a little earlier, they could have been cardioprotected and diagnosed and catheterized. So meaningful chest discomfort, meaningful chest pain. History, most important in getting that information. And once you get it, then you act accordingly, because you know that he's going to be not allowing you to do what's proper for him. Now, the question is, how do you accomplish that? Okay? That's where we are. Okay, I'm going to act this one out. You all have a chance. We're interested in seeing how coronary caregivers, how they're able to perhaps, you're the victim. Not the victim yet. Okay, if you had this, if you were lying on the ground, you would know what to do, and he was not breathing, you check everything, you know all that kind of stuff. I mean, I don't have to teach you that, ABC, doing things like that. I can take it for granted that. Okay, if he's got the Mack truck sitting, do go some of that. Why don't you go through that aspect? Okay, and you question. If you're with him,
Okay, Ken, what seems to be the problem?
Hurt. Just hurt like crazy.
Okay, whereabouts does it hurt?
All over.
All over?
Yeah.
About when did this start happening?
Oh, last night.
Last night?
Yeah.
Has anything like this ever happened to you before?
No.
No? On a scale of 1 to 10, about how bad is the pain?
Well, which is which?
Well, 10's the worst, 1's real minor pain.
10.
10 is worst pain. Am I getting any other history of
anything you want to do? Do you want to call some paramedics? Or?
Okay, how does he look right now?
Well, he looks clammy, pale, and he's getting ready to pass down. He's going to puke on you.
Okay, Ken, how about I call an ambulance, get you in the hospital, get checked out, okay?
It really hurts. I don't care.
Okay. Call paramedics for me.
Okay. Okay. So he helped you because he was ill, and you know he was, you know, you could easily overcome him because he, you know, there was nothing really resisting you. He was helping you, and then you had the knowledge of the pathology, and then it becomes somewhat easy. Not always easy and things like that. Some people actually, when they get the Mack truck, got to pass out before you bring them in. You will know. I mean, that's really intense denial, things like that. But the question comes up, what do you do with less than that? We'll turn it to 2 other people right now. How about you two? Who wants to be what? Okay, not the victim, the one with the chest discomfort, because you're not a victim yet. And you were her friend, and you're in a conference with her, and she tells you the history that she's had some discomfort off and on during the night. And then it's lasting a little bit longer. It lasted half an hour earlier this morning and went away for a couple hours, but now it's back and it's lasted about 10 minutes. But you've got things to do. She's got things to do. She's got to finish her class and she's got to go to work afterwards. And then you have to get home and do some housekeeping or some store shopping or something like that, whatever it is. I'm sorry. That's where you are.
Where does it hurt? How do you feel? Could you
Don't look
describe
sick
the
now.
pain?
Don't look sick. I'll make it easy for her.
It went away on there.
You keep denying. Let her try to overcome that.
Well, could you tell me a little bit about how it felt when you had the pain? And how long it lasted? And has this ever happened to you before?
Well, you know, it happened last night. But it just comes and goes, and it's just a slight pain. Sort of like a toothache.
How would you feel about going to the hospital to check it out?
I don't have time to do that.
Well, I think it might be a good idea.
I don't have the money either.
You said you've had it before?
Last night,
Any time before that? Was there anything that you did to relieve it?
I laid down on the bed.
Did it hurt at any school while you were sleeping, or were you active while that when it happened?
I thought it was just, maybe something I ate when I was sleeping. While I was sleeping, I woke up and maybe it was just something I ate. Gave me the pain.
So it's just a toothache.
Yeah, I felt like it didn't hurt.
But you definitely don't want to go to the hospital, and you keep telling her that, okay? But unbeknownst to you, somebody's called a paramedic, and you're kind of on the scene, and you're going to be the answer to everybody's problem. You're going to, okay? You say, identify yourself, and you're going to get her to come when she was not able to do so. Let me see what your technique is. You don't have to kneel.
I have to get the inside to come with it.
Well, yeah, because if you're going to unstable angina, if you think she's got meaningful, say that you got the history, and she does have discomfort off and on. You're convinced of that. You want to get her to come, but she was not able to do that. And you're here upon the scene, and she's telling you she doesn't need you.
Did you call them? I don't want you to call them.
I thought it was a good idea to have it checked out. I know, it just,
You don't have time.
I think she has your best interest at heart. Okay, you had some chest pain. Okay, you've had it before, it went away. That was with relaxation, but every time you do something, it comes back. Something's going on inside that,
Well, it keeps going away.
but it keeps coming back. Okay,
Not all the time.
well, when does it come back?
It's different times, different
What are you doing when it comes back?
Usually running.
Right. Kind of physical activities, right?
didn't you say it got worse or lasted longer?
Well, the past time, yeah.
But what happens is when you relax, it goes away, and then when you get all physical, it comes back. So it might be away now, but we're going to get physical again, and it's going to come back again.
Is it bigger
Right.
worse?
Yeah, I guess that's your point.
So what do you say you come with us?
Do you ever get physical? I mean, if you really feel that's what's going on, do you just, can you do that?
No.
Okay, what are you told to do? What are you told you can't do?
Forcibly take them.
Against their will, their
Right.
word. See, this is the heart of the matter, if you want to get to it. Fun. You can't do what's best for that person, and since you can't overcome that, and you get a conscious patient, you don't have someone that's just lying there, that's or an MI that's it's an easy person to deal with. You got someone who's conscious and really intensely denying it, and you can't overcome them, and you can't physically take them. So what are you going to do?
Try to convince them to come. I mean, I can't say,
You call a
come on,
policeman?
come with me. No, because they